know, we will be recording this meeting. We have things set up so that only the captured screen and the speaker will be recorded. So I don't think there's any concerns that you will be recorded if you don't want to be recorded. We will also only record the presentation part of the seminar, and we will not be posting the discussion part of the seminar publicly, so that people can feel free to speak without worrying about those privacy concerns. So it is my great pleasure today to kick off the year with Dr. Michael Brauer, who's been my mentor for many, many years. Dr. Brauer is a professor in the School of Population and Public Health at UBC, and also a principal research scientist at the Institute for Health Metrics and Evaluation at the University of Washington, where he leads the environmental risk factors team for the global burden of disease analyses. His research focuses on environmental impacts and human health, with specific interests in air pollution and the link between urban form and population health. Mike is starting us off today with an extremely timely and interesting insight into the work that they have been doing around universal mask use related to COVID-19. So I'm sure many people are very interested, and I will let us get going. Welcome, Mike.
Great, and if I can just get an okay from you, Sarah, that you can hear me okay?
I can hear you perfectly, and I see your slides very clearly.
Okay, and you can see me, maybe? Okay. So thanks very much. As Sarah mentioned, I'm going to present some work on some global projections of potential lives saved from COVID-19 through universal mask use. And this work has been conducted in the role that I have at the Institute for Health Metrics and Evaluation, and just want to acknowledge a large group of people, some of whom are mentioned here, who were contributing to this work. And actually, my contribution is actually a rather small part of this, but I still thought this would be useful in terms of just providing information and also providing some of the links to some of the hygiene principles that we have here. So to start out, we're actually going to do a quick poll, and I think Sarah can launch that, just to ask about perceptions of the audience about mask use. So if you can all complete that poll.
I see answers coming in, so I think people can see it. Can you see the answers coming in, Mike?
I can, yes. So, so asking about perceptions, it looks like we're getting, most people are saying that face masks should be mandatory in all indoor public places, and with sort of the next nice answer, face masks are only useful when physical distance between people cannot be maintained. So I think we will, let's end this polling now. I'm just going to move to the next slide if I can. Okay, and just it's quite interesting actually to see that response. And just today, there was a broadcast email that came out from UBC that UBC actually changed their policy. So previously, UBC had strongly recommended the use of non-medical masks when indoors on campus, and that was actually changed today. So actually mandatory use of non-medical masks indoors on campus. That will be effective on Wednesday of next week. So we can have more discussion of this at the end. So what I'm going to talk about today is basically start with some background on how do masks work. And this will actually get into some of the aerosol physics and hygiene principles that I know best, and that certainly our students will learn or have learned. And then talk about this specific project. And basically this modeling has three components to it. So we merged information from the literature on mask effectiveness. So these are from trials and observational studies. combine that with some surveys that are underway around the world on mask use, and fed that information into a predictive model that is being run operationally to forecast deaths related to COVID-19, and basically ran two scenarios, sort of a current scenario under current conditions, and then a scenario where the population is using masks at a high rate. 95% of the population is wearing masks when they're outside of their home. Use that to calculate avoided deaths on a country by country basis and over time. So I'll provide all the details of that. So before I go there, we will just do another poll on, for those of you who do wear a mask, just getting some information on why you do that, how you actually think it works.
I'm just going to confirm that folks are seeing this poll.
No.
Okay. Let me see. Oh, let me try this. Sorry, I'm a little bit new to this.
That's the same one as the first one.
That's the last poll.
Yeah.
I think polling number 2, launch polling. There we go. Is that good?
We can see it now.
Perfect.
Yeah,
Thank
that's
you.
good. So the question is, if when you wear a mask, what is your primary motivation? Okay, it looks like we're getting some pretty consistent results here. So about 60% are saying to protect others from potentially being infected by me. And then 28% to protect myself from being infected by others. And then 10% to make others feel more comfortable in my presence. And I think that's, those are great, and I would say very consistent with the literature. So no surprise, but we've got a audience that's quite well versed in the topic. Okay, so how do masks work? So I'll just go through this very quickly, but the idea would be that they are quite effective in blocking the exhalation of aerosol particles and droplets for individuals that may be infected. And then they also provide some protection for the wearer if they come in contact with somebody who is wearing or is not wearing a mask, who may be infected and is exhaling these particles. And we'll talk a little bit more about what they are. So how do masks work sort of physically? So if you think about, and this is regardless of whether we're talking about COVID or air pollution particles or particles that you may encounter in an occupational setting, the primary mechanism is what we just call mechanical filtration. And then depending on the materials, you may also get some additional protection by electrostatic principles. And actually, when you think about an N95 mask, it's really those electrostatic properties that give you that very, very high rate of protection, or that very, very high level of filtration. The cloth masks, so the face coverings that we're primarily going to talk about today, most of that is due to mechanical filtration, but depending on the materials that you have, you may get some electrostatic properties as well. And that mechanical filtration works on several different mechanisms. If the particles are very, very small, they essentially have random motion as they're moving through the air. And I think you can probably see my mouse here, hopefully. And that's Brownian diffusion, and just randomly, actually, those particles will come in contact with fiber of the mask material, And essentially, any type of particle that we're talking about, when it comes in contact with fiber, it sticks to that fiber. And then you need to actually provide lots of force to re-suspend it or to re-release that particle. So essentially, once that particle comes in contact with the fiber, it stays there. But that's only relevant for very, very small particles. And it's not a very effective mechanism for other sizes. The most important are, one is sort of the obvious, which is what we just call physical interception. So that, again, is just the particle coming in contact through its own motion. So the particle happens to come in contact with the fiber of a mask. And so you can imagine that particles will, if you imagine a mask as a web or a weave of fibers, there are little holes that allows air to go through, but some of the air streamlines will actually intersect with a fiber of a mask, and that physically will intercept. One of the most important mechanisms, however, is what we call inertial impaction. And again, those of you who've had the measurement and sampling classes know all about this. This is the same way that we actually collect particles of different sizes to sample them from the air. And this is basically the acceleration of a particle due to the force, in this case of breathing in or breathing out, will accelerate those air streams, and the gas molecules, so that air stream will actually try and move around the fiber of the mass. So it will go through the path of least resistance, but those particles actually have momentum, and they're not actually able to change their direction. So while they're being accelerated, they basically slam into the fiber of a mask. So it's by this property that actually makes masks much more effective when you're exhaling than you're inhaling, because the force of your exhalation is actually accelerating those particles into the fiber of the mask. Whereas when you're inhaling, first of all, you're actually not using as much force for your inhalation, and you're actually drawing particles in from a much greater distance. So this is actually the principle by which masks actually block more particles in exhalation than they do in inhalation. And this is now just talking about the overall filtration efficiency of masks. And on the basis of those three mechanisms, the size of the particle will affect the filtration efficiency. So there's a minimum at about 0.3 micrometers, and particles that are larger and smaller than that will be collected more efficiently. So for example, by definition, an N95 mask has 95% capture at what we call the minimum size the size of maximum penetration, which is 0.3 microns. A HEPA filter, same thing, it's 99.97 effective at that minimum size of 0.3 microns. And when we're talking about COVID-19, so the SARS-CoV-2 virus, we actually have a range of particle sizes. So if we are infected, so if I am infected, when I exhale, even though the viral particles are very, very small themselves, we're never exhaling pure viral particles. They're coated with water and moisture because our airstream, actually when we exhale, we saturate that air with humidity. So when we exhale, we're actually exhaling a range of sizes of particles, viral particles, that will actually shrink as they go into the air, as that water actually evaporates in the air. So you think about it, and I'll show you some images of this. The closer you are to someone's exhalation, the larger the size of the particles, because they're coated with more moisture. The farther you get away from that person's exhalation, the smaller the particles. And so here's just some visualizations of this. So this is a homemade face mask. This is 2 layers of cotton. And you can see that, if you exhale through this, there's some leakage through the top of the mask, and there's some leakage through the mask. And the amount actually will change at different times after the initiation, in this case, of a cough. So it's very complicated in terms of the forces and the velocity. Again, if you cough or you sneeze, you're really expelling those particles at high velocity. So there's lots of acceleration, lots of that inertial impaction that actually makes it more efficient. It's a little bit counterintuitive here, actually makes it more efficient for trapping the particles because of that force. And then looking here at speaking, coughing, and sneezing, so you can see the differences in the exhalation. So a lot more particles exhale by sneezing and coughing than by speaking. But masks are actually almost equally effective. And again, that's because of that issue of the inertial impaction. And in some cases, you can see, for example, here, that coughing and sneezing, like with a 2-layer cloth mask, there's actually more particles that get through. Yeah, in that case, and that's due to that leakage as well. So I'm not going to spend a lot of time on sort of what kind of mask. There's lots and lots of papers on this. I would say there's still a lot of material that materials and combinations that are being tested. There's lots of literature on this. This is a really good website. So it's built in nv.com from the Illinois Institute of Technology, which gives a lot of information on sort of what kind of mask. And this is just one example of some testing that have been done looking at everything from a fitted N95 mask to a common surgical mask to various combinations of different types of cotton or sort of more homemade masks. And again, I wouldn't say anything definitive, except that all of the sort of homemade masks are less efficient than a fitted N95. But when we're talking about the general population, we definitely do not recommend these N95 masks for general population use. First of all, if they actually fit well, they're extremely uncomfortable to wear. And if anybody's actually worn one for multiple hours at any kind of activity, you know actually how uncomfortable that is. But more importantly, we want to reserve these for the healthcare population who are facing very extreme sort of exposure situations. This is instead of actually these kinds of studies where you're basically looking at penetration through face masks in an experimental setting. This is actually the kind of study that I think is actually much more valuable. This is a rather unique study, but I think there are more like this on the way. And what these researchers did here was actually took patients that were actually infected with COVID. And so you can see on the left-hand side, this is just confirmation that they had viral particles, either by nasal swab or by throat swab. And then they had them exhale into air and measured and then did air sampling to capture particles of different sizes that these subjects had exhaled, both with and without a mask. And what you're seeing here is with a mask, both the droplets, so these would be particles larger than 5 micrometers, were 100% removed. Again, through so the exhalation of those particles was removed 100% efficiently through the use of a mask. In this case, this is a surgical face mask, so not an N95, but a common surgical mask. And then also the same kind of results for smaller particles, so the aerosol particles. Again, they made a very binary distinction between particles less than 5 micrometers and greater than. Again, 100% removal of even those very, very small particles through the use of a surgical face mask. So this is really kind of a real world type of experiment, patients who are actually infected and just breathing. So nothing sort of extraordinary here. And similar kinds of studies done, in this case with influenza. This is an older study, but it's interesting because in this case, actually, the masks were again, very effective for the larger particles, so those droplets, but not nearly as effective for the smaller particles. So suggesting that there's actually differences between different types of viral particles, in this case, influenza versus the SARS-CoV-2 particles, so that actually masks may be especially effective for SARS-CoV-2. Okay, so that's just all background, and I'm just going to go into the specifics of the project that I want to talk about. So let's start firstly with the mask effectiveness. So this is what we're doing now is taking information from all kinds of trials and observational studies that have been done previously, trying to get an estimate of how effective are masks in actually reducing infections in the population. So this is an example of a sort of typical study. This is actually one of the few studies that, in fact, the only study that has been done with SARS-CoV-2 with a non-medical or non-healthcare population. So what you're actually doing in these studies, you're looking at secondary infection in this case. So there's somebody in a household who we know actually has the disease, who's infected. And then you look at the other household members. So you know that they're going to be in close contact with that individual. And typically these tend to be retrospective studies. So you're asking people, what precautions did you take? And so did you wear a mask? What kind of cleaning did you do? And all the kinds of things. And you can pull out from that and then look later on at, did any of those other household members become infected? So what we would call secondary infection. You know that there was an index case in that household. And in this case, they found that mask wearing, and it's a little bit hard to see here, but had an odds ratio of 0.21. So for those of you who aren't familiar with these odds ratios, that's saying that there's 80% protection through wearing of that mask. So an odds ratio of 1 would suggest that there's no benefit, no protection from wearing that mask. And something greater than 1 would say actually that it's harmful. You're more likely to be infected if you wear a mask. In this case, 80% reduction through the use of wearing a mask. So that's just one example of the types of studies. What we did was we actually looked across all the studies in the literature that we could identify. So in total, 40 different studies, but with 63 sort of separate observations. And that's because we might be looking at different levels of mask use, different combinations of diagnoses and all kinds of things. So studies may actually have more information from a single study. These are the kinds of features that you have in the different types of studies, and what we extracted was the location of the study, whether it was COVID-19 or SARS, so because that's a highly related coronavirus. What type of mask? So was that a cloth mask, or was it we grouped everything as medical, surgical, or N95 masks? Was the diagnosis of disease done clinically, or was it laboratory confirmed? What setting, and this is very important, was this in a healthcare setting or a general population? And what type of control group? And really what we're interested in is trying to understand information about the general population use of cloth masks. But you can see actually that's a small fraction of the overall studies. But what we did is we employed an approach called meta-regression, where you essentially take all this information together and you can look at sort of all the combinations and try and distill the information about all of the different types of comparisons across all the different types of studies. So these are just all the studies, and hard to see here, but this is the line of 1 for the relative risk. Again, anything to the left suggests that wearing a mask is protective. Anything to the right, it's harmful. The points are the mean estimates of the relative risk, and the lines show you the confidence intervals. So studies where these lines are very large, we're less confident in the result, less precise result. Studies where it's very small, it's more precise. And the size of these squares just shows the size of the study. What you can see from here is the majority of studies show protection. There's a few studies that show that mask use may have been harmful, but they're actually very imprecise. And then we start sort of distilling this information. So this is now looking across those features that I mentioned. So we actually pulled out the features and the comparisons with the individual studies. And this is just looking at each factor on its own. So not adjusting for other factors, but you can see that whether it's a medical mask or a non-medical mask, they're both protective. There's some differences. And I won't belabor this, but basically, none of those characteristics were really strongly influencing the level of protection that you got from the studies in the literature. This is really the sort of take-home point. We're focusing on medical masks in the healthcare population, all the way to sort of what we're most interested in, which would be non-medical masks amongst the general population. And what we see is, while that estimate is very uncertain, the mean estimate is about a 40% reduction in infection for the wearing of non-medical masks amongst the general population. And as you move to these different sort of comparisons, you get a little bit greater protection, but not actually that much more. So even in use of medical masks amongst the healthcare population, you're only getting about a 56% reduction. So not that much more than what we see in the general population. I'll also point out that, again, all of these studies and all of their confidence intervals are quite far to the left of the line of 1. So they're all showing benefits, and there's no indication from this analysis that there's anything harmful about wearing a mask in terms of your ability to become infected. If you just look at the studies of SARS-CoV-2, those individual studies range from between about a 30% to 100% reduction. Those include mostly studies of healthcare populations. The single study that I just showed you before of non-medical mask use in the general population for SARS-CoV-2 showed a 40% reduction for any mask use and about a 70% reduction for consistent mask use. So this overall 40% reduction that we're estimating and using in the forecasting, I would say it's quite a conservative estimate for the case of SARS-CoV-2. And this kind of work is supported by some quite interesting case report series. This is my favorite one. This is a case reporting of 2 hairstylists. I believe this is in Missouri, who were infected, did not know it at the time. Actually, one hairstylist infected the other. Once they learned of their, were wearing masks because it was mandated in the community, but didn't know that they were infectious, so they continued to work, and saw 139 different clients, all again wearing masks. So 2 hairstylists, both infected, 139 clients. None of those clients actually became infected, even though they were in close contact with those hairstylists. And there's a few other similar types of studies. There's a study of Swiss soldiers that were in training where some individuals were infected, use of masks led to actually no symptoms, even though some people were infected. So suggesting that even if you come in contact with somebody who's infected, if you're wearing a mask, you may reduce your dose of virus. So that offers some sufficient protection so that you'll develop antibodies, but you actually won't develop any symptoms. And there's a study of healthcare workers in Boston that showed that universal mask use was associated with a lower rate of positivity in that population after adoption of universal mask use in the hospital setting. So we took that information again from the literature and combined it with mask use surveys, similar to one that I'm just about to ask you now. These are done by a number of groups. So Facebook is actually surveying every day. 23 million users around the world in 102 different countries, asking about their mask use. In the US, there's an outfit called Premise that asks about mask use, and then YouGov surveys about 500,000 participants in 29 different countries, and we took all this information and combined it together. So let's ask about your mask use and do another poll here.
I think that should be it.
Yeah, looks like it's working. I'm gonna let this one go to the end until we get everybody responding.
We might not get everybody,
All
Mike.
right, I guess we'll wait for a minute.
If you haven't answered the poll yet, please do.
If you care to.
If you care to.
Okay, so it looks like we're around 40%, and I realize there's sort of always frequently, there's some subjectivity there, but it looks like we're close to 40% there. Okay, great. Okay, so this is what, this is data from sort of the last compilation, which is August 31st. So this should get updated in a week or so. But you can see there's actually quite high variation around the world. So Singapore is one country. So that's actually where the highest mask use is, about 95%. And that'll be important because that's actually what we use in the universal mask use scenario. But you can see mask use is very high throughout much of Asia, as well as southern sub-Saharan Africa and throughout South and Central America. And then it really varies a lot. And so quite low use throughout much of North America, much of Europe, especially the Scandinavian countries, and through parts of Northern Africa. I was going to show you some trends over time, but I think we'll sort of skip that, and I can show that to you in a different way. This is just looking at Canada. So these are actually data from a survey done August 25th, just projected, but in BC, from those surveys, about 29%. So this population that we just surveyed that's listening to the seminar, we were a little bit higher than that. And then Ontario has the highest use in Canada, so much higher than BC, at around 73%. And I actually don't know sort of what the mandates are. There may be some requirements in Ontario, and if somebody wants to let us know about that in the discussion, that would be great. Just some information to mask use from these surveys by gender and how that varies around the world. Not huge differences. So men and women tend to wear at similar rates. The one part of the world where there are pretty big differences is South Asia, where much higher mask use amongst men than women. And you can see actually also in all these locations, for the most part, there's been increases. This is just showing since May to August, increases. But some parts of the world, particularly Southeast Asia, East Asia, where mask use had always been high. So always sort of 60% or so. And even actually was high sort of before the pandemic really began. Mask use by age, not a lot of variation, although there tends to be less mask use in the younger segments of the population and the older segments of the population. So the lowest are in 18 to 24-year-olds and in those greater than 65. And that's fairly consistent by region of the world. And not a big surprise here, but if you look at it by urbanicity, higher mask use in cities and towns compared to rural areas, and that's likely just reflecting the numbers of contacts that people would have, or the density of interactions they would have with other people. So that's sort of the survey data. So that information plus the mask use goes into this this mathematical model, which is SIER model, which stands for susceptible, exposed, infected, recovered. And what we did is we looked at two different scenarios. One is sort of a business as usual scenario, and one is in a scenario where 95% of the population is wearing masks, and that's that number from Singapore. So we're saying that this is physically possible or behaviorally possible because there are some places in the world where 95% of the population is wearing masks. I won't go into the details of this here, but essentially what you're doing is we're taking information actually from deaths and the relationship between deaths and infections, and using that to understand the how effective is the virus transmitted, how effective is that if you come in contact with somebody who is susceptible and you are infected, how likely is that person going to become infected? And then if they are infected, how likely are they going to die, be hospitalized, or recover? This is a model that's actually being run now for essentially all countries in the world, and actually subnationally in many locations. So it's being run at provincial level in Canada, the state level in the US. There's lots of limitations of this, and I won't have time to get into that now. The sort of localization part of it and the forecasting relies on a number of these covariates. So we're taking information from what we understand about the past patterns of the pandemic, projecting that into the future, and projecting that to other locations based on these features that we actually know are related to the transmission of the disease. And the things I bolded here are the things that actually are time varying. So you can think about the mobility of the population. Mask use is also time varying, that changes over time. The testing capacity, and a big driver of this is the seasonality. So, and we use actually pneumonia seasonality to predict this trend. This is one of the reasons that you've probably been hearing a lot in the news about why we're expecting things to get worse in the winter, because we've seen actually in the Southern Hemisphere and with other respiratory viruses that they have this strong seasonal pattern, and COVID-19 seems to track quite well with pneumonia seasonality. And in Canada, we see, for example, that this just shoots up as we get into colder weather and sort of peaks around January or February. So as I mentioned, we ran two different scenarios, kind of a reference scenario where mobility patterns and testing evolve according to the past trends, as well as using data and sort of always updating this as new data come in. And then this universal mask use scenario where we're saying that that either a mandate, such as something similar to what UBC just put in place, or campaigns lead to scaling up of mask use to that high level seen in Singapore within 7 days of that mandate being enacted. If you want to look at sort of what is in place around the world, this is a really great website called Masks for All, and it will show you exactly what sort of restrictions are in place in different parts of the world. So these are the kinds of trend information that go into the model. So I mentioned the source of the mask use surveys, and currently globally we're at about 60%. And what you can see in this green line is if we enact one of those mandates and then quickly get this change where the population, let's say, would be up to 95%. Mobility is tracked from cell phone use. So Google, for example, is looking at mobility, and we use this information again on a location-specific basis to understand how mobile the population is. So globally right now, we're at about 19% below pre-pandemic levels of mobility. It's becoming increasingly clear, however, that sort of these measures, these cell phone-based measures are not really a very good indication of the contacts that people have that may lead to infections, but it's sort of the best information we have at the moment to predict the course. And you can see that this has been sort of slowly increasing and is likely to continue to slowly increase under these scenarios. So what do we see? And I'm just about to wrap up in terms of the talk here. So this is sort of the scenarios, and this is the reference scenario, what we think is most likely to happen, looking out from sort of the present until January 1st. Where we're estimating somewhere, above 2 million deaths globally, but only down to 2 million under this universal mask use scenario. Here's the actual numbers. So 2.8 million deaths, but that could be reduced by about 800,000 through that universal mask use scenario. Sort of the worst case would be actually no improvement in mask use and actually removal of social distancing mandates, and the projections there are that we would have up to 4 million deaths by January 1st, 2021. This is just looking at it by country. So again, the global numbers you see here, some of the larger countries in the world where you can see that you can get somewhere around 20 to 30% reductions in some cases. Countries that have very, very low levels of current mask use, like Russia, where you would get sort of a 72% reduction in the projected, again, these are projected deaths under the two different scenarios as of January 1st. Bangladesh, a similar example. So higher levels of current mask use, but actually quite early on in the pandemic. So actually rather low numbers of cases right now. And those are the places where masks will be most effective. So places where there's still a lot of potential transmission or a lot of expected transmission in the future, but also places where there's relatively low levels of current mask use. And you can contrast that with a country like Spain. Even though there is a lot of transmission still, mask use right now is 90% in Spain. And so actually the sort of lives saved or potential lives saved through universal mask use is just getting this 90% up to 95%. So there's really not much more to be gained in the example of Spain. And Canada's sort of right kind of in the middle there, that we have kind of a moderate level of mask use, 52%. If we got up to 95%, we would save somewhere around 30% of these projected future deaths. Now, again, this is all projected, so there are many other things that may happen, many other things that we can do in Canada so that we will never reach this number. So just to end up here, so through this sort of forecasting, universal mask use can lead to substantial numbers of avoided deaths. And I was going to show you a little simulation. Maybe I'll just go back and do that really quickly. If we can here. And this is just sort of what happens in these models. So we've got an infected person in brown, and we've got uninfected people. And on the left-hand side, no use of mask, and the right-hand side, use of mask. And I'm just going to click this, and it's going to start. And you can see that on the left-hand side, people are quickly becoming infected. And you can see at the peak of this, about 90% of the population is actually infected. And whereas under the mask use scenario, at the peak, only about 50% of the population is infected. And in both cases, eventually, there's no more people left. So people have developed immunity, and the numbers become lower. So let me go back to slides. Okay, so, and as I mentioned, the most benefit is where and when mask use is currently low and where there's ongoing transmission, or we could just simplify that by where there are deaths that still are increasing. Masks complement physical distancing without severe economic impact. So that's really one of those strong sort of benefits, is that it's pretty easy to wear a mask. It's much more difficult to say people can't go to work, or we have to put in sort of complex controls. They can also delay the need for more severe mandates. So in many parts of the world, masks, and in fact, most places, masks are not by themselves sufficient. But if we want to avoid very, very severe mandates, they can actually help delay that, and perhaps delay that until the seasonality improves, or delay that until a vaccine is available. Masks may also be really important where distancing is not feasible. So where people must be in close physical contact. And I'm just going to put in a plug for the seminar next week. So Angela Eichelbosch is going to talk about engineering controls, so things like filtration and ventilation, which are other approaches that may be necessary in places where masks cannot be worn, or situations where you need to complement mask wearing with other mechanisms. And finally, masks are affordable, and very importantly, they're equitable. So there's really not barriers for people to have masks, whereas you can think about many of the other solutions, some of them are not feasible for many segments of the population, and perhaps segments of the population that may be at greatest risk. So if you're thinking about a highly complex ventilation scenario, or air filtration, or air disinfection, or people who have to be in close contact, there's not a lot of things that can be done, but masks are something that everybody has access to. And just for the students, those of you who've been in the program, you're well familiar with sort of hierarchy of controls that we commonly use in hygiene. This has been sort of adapted for COVID. Here's just one sort of adaptation. This actually came out, I would say, rather early in the pandemic, when we weren't that clear on the routes of transmission. So I would actually adjust this with my arrows and say that I would put, based on our understanding now, the airborne route being much more important than the sort of surface route, that masks and administrative controls in terms of physical distancing are probably more important than what are listed here as engineering controls, which would be the hand washing and surface cleaning. And perhaps sort of thinking about, in our traditional hierarchy of controls, we always say that personal protective equipment is sort of the least effective, it's the least desirable, the least efficient, because it has to be done on the individual level. Whereas all of these other things are upstream and can be done sort of at a population or at a group level. So if you put in an engineering control, let's say in a building, or in a workplace, everybody in that workplace benefits. You don't have to worry about individual adherence or individual protection using use of personal equipment. But in this case, because of the affordability and the equitable nature of masks, and because the fact that there's very little risk or very little harm in wearing a mask, I would actually raise that up the hierarchy when you're talking about the general population. So this has gone on far too long. I guess there's a little bit of time for discussion. I'd be happy to take any questions or have just open discussion.